Welcome back for plenary session 7 of day 1 of Rhythm Interventions Online 2025. The focus of this session is LAA management in the age of PFA. This should have been a presentation and discussion session. For the presentation, I'm sure we will welcome within the next minutes Boris Schmidt, my friend and colleague. But apparently he is still stuck somewhere in the, maybe he has some trouble with connecting at this point in time. But until then, Boris will connect. I would like to welcome back our panel again, Andrea Sarkozy in Brussels, and of course, Devi Nair from Jonesboro, Arkansas. And Boris is not with us yet, but I'm sure we will still be able to manage to discuss this session, even if Boris may show up a little later. So let's start. LAA management in the age of pulse field ablation. And of course, I'm glad I have two super experts in the field with me, and we will be able to discuss the pro and the cons. And maybe I start off with a little teaser, because tomorrow, Devi and Andrea, we are going to transmit a live case, a truly live case from Frankfurt. And we scheduled a patient in which we are going for a concomitant left atrial appendage closure together with pulse field ablation. Maybe I start with Devi, very much in general, very brief or and very general. Do you think this is the way to go? This is the future. This is the strategy for our AF patients to organize best care, or do you think this is maybe still something which maybe you guys in the United States do, but again, for us in Europe, it is still some way to go?
Well, Julian, I think it's a great question. I think, we're in a different era now than what it was 2 years ago. As we were, I remember 2 years ago, we showed the first concomitant case on RIO. And we've come a long way, right? We've come a long way with having a tool for ablation that is safe and relatively efficient. And we've come a long way with LA closure technology. So now you have two technologies that kind of address that AF patient, not just for rhythm management, but also for stroke prevention. And then we have a lot of clinical evidence that got generated in this last year. Some from Option, even though Option was not a concomitant trial, 40% of patients in Option were concomitant patients. So that gave us a good amount of randomized data. We also have patients from many registries, both from Europe and from US, that showed data on the safety of concomitant procedures. And of course, in the US, having a DRG that allows for reimbursement kind of spearheaded the whole concomitant thing. I can tell you, without that concomitant DRG, we would not be sitting here talking about this stuff, at least from the US. But with that DRG, we've definitely seen an increase in uptake of concomitant procedures. Now, for me personally, I will say that today, LA closure is still a therapy that I only use in patients that are high risk of stroke and have a contraindication for oral anticoagulation. And they still have a high AF burden, or they are at risk of having a recurrence of AF. So patients who come to me for concomitant are patients that are coming to me for LA closure, and they have a high stroke risk, and they obviously have a reason to not be on a blood thinner, but then they will benefit from rhythm control strategy. And in that way, I get to tell them, hey, while I'm there for LA closure, can I also add AF ablation to it? So it just kind of helps me bring AF ablation more into LA closure than the other way around. And I think we have to wait and see what Champion and Catalyst show and see where LA closure goes for primary, prophylactic therapies. But right now, it's still a therapy that I use in patients who are not candidates.
Right. Thank you. That's interesting. You look at it from the perspective of patients who are already scheduled basically for LA closure for whatever reason. And then you ask, okay, maybe if once we are there, we can also do, maybe because of PFA, also do pretty quickly and do ablate and to do isolate or ablate atrial fibrillation. So this may maybe lead my next question over for Andrea. You mentioned, Devi, also the option trial, but we also have more recent data from other studies indicating that we do reduce, just by AF ablation alone, we reduce probably the AF burden. And this in turn will probably or could probably lead also to reduced risk of stroke per se. Any thoughts, Andrea, in that context of course, rapidly evolving data on this perspective on the concomitant LA closure and AF ablation?
So I think I look at it exactly from the other way, because I usually get patients referred for the AF ablation. So when I think about concomitant procedures, I look at my AF patients, which are the ones who would benefit with a concomitant LAA closure. But I agree with Devi that from that point of view, I think when I consider concomitant procedure, it's in patients who have a very high risk of stroke. But who also have a very high risk of bleeding, especially on after the initial few months, and in those patients where we really choose for rhythm control. However, I think with the closure AF, with failing non-inferiority in patients with very high and health score, I think we may need to wait for more data, as Debbie was also saying it before, offering to all these patients the concomitant procedure.
Yeah, thank you. It's more, let's say, our and I share it. It's been the traditional way of looking into these groups of patients. Even though I think the patient characteristics in closure versus, for instance, options are completely different. This is something, of course, I think we also need to state, right? I think in closure, patients had a very high annual mortality rate, for instance. It was almost two-digit numbers. I think it was 13, 14%. So this is definitely, of course, not our typical AF ablation cohort. But again, if we combine and if we decide to combine both procedures concomitantly, as Devi, as you said, 40% in the option trial, would you, and considering the fact of using PFA as the ablation energy source, would you go for ablation first and then the device, or the other way around? And why?
Well, it's a great question. I think, to me, I mean, there are two ways I look at it. I would say 90% of my patients, I would like to do the ablation first, and if the patient is planned for a concomitant procedure, I like to take care of the AF part first, address the ridge. I want to have access to the concomitant ridge, and not quite sure what areas I would want to ablate. I don't want an interaction between my PFA catheter and the LA closure device. So take care of the pulmonary veins first, make sure I'm able to deliver the durable lesions that I want, and then move on to LA closure. And one of the things I think when you do it that way, you have to be careful about is, making sure that you address things like edema within the appendage and size the device appropriately. And there are workflows to address those. Now, in about 10% of patients, I will actually do the LA closure first. Sometimes in a concomitant manner, sometimes in a sequential manner. But those are patients that are truly, like, they cannot take anticoagulation. They have quite a bit of LA sludge. They're not quite thrombus, but they are on anticoagulation and still have a lot of limited flow within the appendage. And I even with the high ACT of 350 and above, I still see that kind of sludge pattern within the appendage, and I would close those with the plug device. And of course, it becomes kind of challenging to use a dual seal device at that point, because you get limited access to the ridge when you do it that way. So I usually will use a plug device in those first, then go on to doing the AF ablation, and being very, very careful and cautious about what I do with the splines, and I don't cause any acute positional change of the newly deployed device, etc. So there's pros and cons. I would say majority ablation first and then LA closure.
Yeah, yeah. Andrea, do you see it, or do you have the same, would you do it the same way in 90% ablation first and then putting in the device? Or would you maybe even dare to say, because I use PFA, and I think, Devi, you mentioned it before, we are entering, and Andrea, no, you also mentioned it, we're entering an era of more permanent PVI even after a single procedure. So because in part of PFA. So would you even say because of this, maybe we can omit the closure device in a couple of cases?
Yeah, I think I didn't answer actually your previous question, which was an excellent question. And I think we are all feeling that the field is going in the same way, that it's very important to look at AF burden. And seeing that the AF burden is critical in stroke risk, and that the fact that we can now we have already 2 trials showing that after ablation, probably due to the lower AF burden, that it's not sure that all of these patients are going to need anticoagulation. I think in my mind, so in these patients, if I think that there is a high risk of maintaining sinus treatment with the ablation and decreasing AF burden. That would be for me indeed a reason to reconsider a concomitant procedure or omit the LAA closure part of it. But I agree with Devi. That's from our point in our center, we also do the same that we first do with the PFA, the PVI, except those patients when I'm very worried about high stroke risk, either having sludge as that we were saying, or for example, a previous LAA thrombus, also with a high risk of bleeding. In the moment when the patient doesn't have a thrombus, I think in these patients, I would also find it clinically more important to close the appendage because the ablation I can do after at any time.
Yeah, right. And Devi, maybe we play a little ping pong. I ask you again one more question. Of course, now the device has been implanted, the atrial fibrillation has been ablated, but very often, of course, or typically for a regular AF procedure, we do not think too much. It's DOAC probably most likely for whatever, 8 weeks or longer based on Charles Vascular. How does the concomitant implantation of an LA closure device potentially impact the selection and recommendation of the post-ablation and therapy anti-thrombotic treatment?
It's again, great question. Obviously, if the patient is coming for concomitant today, at least in my lab, it's because they can't tolerate a lot of oral anticoagulation. And I have to say that, I mean, with the advent of PFA, I'm a little more, with thermal energy, especially with RF, I was pretty strong-willed that patients had to be on anticoagulation for at least 3 months post. And now I'm a little more lenient. I'm good with 6 weeks or more because of the lack of inflammatory response within the left atrium with PFA as much as we see with RF. So with that in mind and with the closure devices, there are many times I would say that if the patient is able to tolerate ideal dose of oral anticoagulation for 6 weeks post, then I would keep them on that minimum. And then sometimes I'll cut it down to half dose for a total of 3 months. Sometimes I just go to half dose DOAC right after, depending on what they can tolerate, to try to minimize the bleeding complications in those patients. So I'm still a proponent of full dose DOAC for at least a short time, but I'm okay with the half dose DOAC if I have to in these patients, especially if that means that would cut down another hospital admission for a bleeding event.
Right, right. Yeah, I think this is always, at least in our clinical practice, sometimes we, of course, in studies, there's a certain protocol, and we used to use DUPT for many, many years for a typical LA closure. Now we sometimes combine DOAC low dose or with a single antiplatelet. So my impression is it's at least it is there's also more options what to do post-implantation, post-ablation, and there's still a lack of uniformity. It's still a little, let's say, very individual, at least, in my personal experience. Again, switching maybe gears,
Julian,
since I don't know
ask you a
what. Yeah,
Can I
sure,
ask you a question? So both
absolutely.
you and Andrea, like, so one of the things that still bothers me about concomitant is, especially in these high risk patients, as their CHADS is higher, many a times it's progressive AF, and yes, we get good PVI with the current tools, but AF is a progressive disease, and as the AF progresses, now we've always kind of went back and forth about LAA being a trigger mechanism for AF, and there are times that we have resorted to LAA isolation uh, in the past, and even though that's not a large percent of patients, what are your thoughts on as the concomitant field grows with these plugs that close the LAA? The access back to LAA, is it going to be enough for us to ablate around the orifice of the appendage to get LA isolation? Historically, that's not been enough. What are your thoughts? I'll ask you, Andrea. You've got lots of experience with complex AF ablation. How do you plan to address all of this in Brussels?
I think for me, so we have been doing this hybrid thoracoscopic procedures for atrial fibrillation, where the atrium was clipped, which meant that although maybe a little bit more distally, but the atrium was electrically isolated because there is no electrical activity behind it. And our experience is that it's the success of the AF ablation is not much higher as with this LAA clipping as without. So I think there are some patients who have an LAA trigger, but I would be a little bit reluctant to consider burning and isolating after the placement of a closure device just for an rhythm management point of view to isolate the left atrial appendage. I think so. In my mind. Especially in advanced persistent AF, I think the presence of AF drivers in the appendage is, in my opinion, is not very high. So I wouldn't, aim at isolating the appendage based on this very limited experience. I think we need trials as for everything. So maybe your next trials could be to when you are doing concomitant PFA with LAA closure, that you randomize the patients to also electrically isolate the appendage versus not isolate, and give us the results. And maybe I will change my mind, but until that, I feel a little bit reluctant about electrical isolation in addition during the concomitant of the left atrial appendage.
It's a great question, and it opens the big box of what to do after PVI, of course. And we published a trial, the Astra trial, in which we compared cryoballoon versus substrate-based modification, and we could not show any, let's say, difference between both strategies. But as opposed to the, let's say, circumferential isolation with a cryoballoon of an appendage, I think there's also a different strategy going for linear lesions, like in roof line, anterior line, and left isthmus line, with the help of VOM or without help of VOM. If those those lines were deployed, the appendage will also be isolated. But it's, of course, a very different strategy behind. This is what we do in super selected cases, not in the first, not in the second, but in, super selected cases, highly symptomatic. And without having randomized controlled data, we feel it is at least better than expected. And this is a pretty aggressive strategy. And in those scenarios, we would always recommend to close the appendage in order to avoid thrombotic, let's say, complications. So yeah, as we all would argue, we need more randomized data on this, but it's a little bit what the old surgeons used to do back in the years. So it is at least the rate of sinus rhythm is better than I would have expected. This is my very, let's say, personal anecdotal, let's say, experience on this. But the redo topic back again. LAA management and PFA, since I think Boris, he will not show up today. He will owe us a couple of drinks next time. But in a repeat procedure, for instance, with an closed appendage, do you think the large anatomic devices are ideal for this scenario, or would you actively select different, families of devices, and which one would you go for? Maybe Devi, I start with you first again.
Yeah, no. I think in a redo procedure for me, I think the question is what is the substrate, and if it's like you said, I don't routinely isolate the left atrial appendage for my first or second procedures. I have to say, historically, I didn't go for it because I felt like the durability was pretty low. Even if I isolated, I felt like 50-60% of them was reconnected the next time I looked at it. Many delayed. I mean, they would be reconnected. They just would be delayed, and so to me that was always one of those things that if you cannot do it well, then why even do it? So I never did it in the past as much, but for a third time redo or a fourth time redo in a patient that has a much larger atrium, if the LAA had to be debulked, I think that's something I was considering. I have to say that some of the PFA technologies, we're seeing a little bit better durability with LAA isolation in these challenging cases. But the concern obviously is that if you isolate the LAA, then they obviously are at very high risk of stroke, because once you have electrical isolation of the LAA with endocardial electrical isolation, now you have mechanical dysfunction as well, and they almost become a reservoir for thrombogenic material. And for that patient, it makes me nervous that that patient misses a dose, say for a simple procedure like colonoscopy. They stop taking it for a day or two, and we have seen patients that have come back with strokes, even missing 1 or 2 days of anticoagulation. So it makes me extremely nervous to isolate someone's LAA and not have some kind of occlusive strategy that is good for them. Now, if I know ahead of time that I'm planning on, it's a redo case, then, and I'm planning on LA management in that patient, then I actually have started looking at maybe even epicardial approaches like the Lariat device for electrical isolation as well as occlusion, but then do PFA and a Lariat simultaneously. So use that as my concomitant strategy, and we've done we've kind of gone that direction. Of course, you can always use epicardial approaches like Andrea mentioned that they use in Brusels. But I think you do have to have a good surgeon like Mark that can pull that off with you guys and have a good collaborative team, right? So I think all of that plays a role. So every site is going to be different, but more to learn on that, right? And maybe Andrea will start the trial for us.
So I think, Julia, your questions are always excellent, of course. But I just would like to mention that I think, so for me, the last patient I referred for a concomitant, one of my patients was a patient who had an empiric, at first procedure for persistent AF and an empiric posterior mitral line. And came back for a redo procedure with a flutter, which was an anterior localized reentry. In a huge anterior scar, and the posterior line was blocked. Now this patient came back, so I only did half of the line to terminate the flutter, but the patient came back again for a flutter. And this patient, for example, I did plan for a concomitant, saying that if I have to finish the anterior mitral line, we will isolate because the localized reentry is on the anterior wall. Then we will have, and the posterior mitral line is blocked. Of course, in these patients, we don't feel good to leave the appendage entirely isolated and not close it. So I agree with Devi on this point that I would never do that. I think so this raises two questions in my mind. One of them is the value of empiric posterior line, posterior mitral isthmus line in persistent AFib without mapping the anterior wall, just empiric in everyone, even with the Marshall or without the Marshall plan. So with or without alcohol ablation, which is for me, this is the reason why I always, worry about this, having seen a few of these patients. And the second one, I think, is a very interesting question, and I would like to have both of your opinions. That what do you think about these patients who, when we do the anterior mitral line and we really delay the left atrial appendage activation almost into the QRS complex, that there is this one publication saying that there is with LAA delayed activation, there is an increased risk of stroke. But in our experience, we are trying to publish this series, but with little success. But in our experience, I do not see a lot of strokes. Actually, I don't see strokes in these patients. But what's your experience? And but I do agree that these patients need a very close follow-up and probably lifelong anticoagulation. What do you think about this?
Yeah, good point. We only have, unfortunately, 45 seconds left, but we could, of course, continue discussing. And it doesn't feel, did we miss a presentation, by the way? But to answer your question very quickly, I agree. I think those patients do deserve oral anticoagulation. I think DOACs are pretty good in also reducing the risk of stroke. And this may be one of the reasons, in addition to the still functioning and contraction of the appendage, even though delayed, of having conferring a fairly low stroke risk, even though I would not dare, of course, to stop the DOAC in this scenario. But Devi, you have the last 30 seconds on this.
Oh, no, I have to say that I think, I agree. I would not feel comfortable stopping DOAC in these patients. I want to come back to the point that Andrea mentioned about empiric posterior mitral lines. I think that's a no-no in our lab just because of the worry. I think if we are doing a posterior line, we always do a substrate map of the anterior wall, make sure that it's clean and clear before we even touch the posterior isthmus. Even though if it's a mitral flutter, I like the posterior line better than the anterior line, but I always make sure the anterior wall is good voltage before we do that. And I think these are things I think we have to keep in mind. Just because it's easy to do doesn't mean we should do it.
What a beautiful final word. Andrea, okay, the very last, yeah. Go ahead.
No, I just wanted to say that I exactly do the same. So in a perimitral flutter, I prefer posterior mitral line if the anterior wall is healthy. I just wanted to say that I entirely agree with that.
Okay, perfect, fine. Thank you very, very much. I really liked our conversation a lot, and unfortunately, still the time is over. And I would like again, Devi, of course, and also Andrea for this beautiful conversation. And next up is, and stay tuned, all the audience out there. The focus is on concomitant LAA workflows, and we are starting in, I think, just 1 minute. See you there. Have a good one.